Go back to technology and AI. And one issue we are having there is that we have existing inequalities in the data, right? So what do we need to do to overcome this? Like the biased algorithms and unrepresentative data.
So I think Rob mentioning that he worked for a women's health company is actually a really great example on how to bring this to life. You know, one of the things that we see in data is there's significant data gaps, and I'm going to use the women's health example. There's just significant data gaps that exist. There are, as it comes, and if we look at, as an example, perimenopause into menopause, in the US that isn't even coded. So if you look at then that it is not coded until a woman has already exhibited symptoms for years, we have a really big opportunity to kind of look at the gaps that exist. So there's a couple of things that we can do. One is, don't have assumptions about what your data has and it doesn't have. I think there's a lot that we believe is in there. Go back and look. And I think this is a really interesting time utilizing data and technology to take it there. And then what are we utilizing the data for? It's to build models, it's to build AI systems. As you're starting to do that, think about from the design, the equity that can be involved there. And one of the key ways we are seeing at Microsoft that this happens is bringing people to the table that represent those diverse areas that you would like to cover. I think one of the things that we see a lot is there will be a lot of US-based data. It will be the global north versus the global south. We'll see a lot of, especially when it comes to wearables, the data coming from the 1% of the population that uses a wearable that has a higher income. And so just checking that over time is really important. The final thing then is, once a model is built, once you're utilizing your AI system, it's not done. And the governance that you have over that model and that system, we find to be really, really helpful. Just an ongoing reassurance, feeding back into the model is one of the ways that you can really overcome this as well.
Perfect, thank you, Jill. And then from like a payer healthcare system perspective, Marcel, like what do you see as like the main challenges, and like is it realistic to have a prevention first model, and can we still finance acute care?
I want to say yes to that.
Try it.
I mean, realistically is the right term here. It will need some time, and it's going to be hard. And you need to bridge the first space where you're trying to move to the second system. And we have tried that in Germany, we're trying that right now in the Netherlands, we've tried that in the UK, and bridge financing alone is not enough. You need to know where the money is going, and that's the hard part. And we tried that with voluntary contracts, and we tried it with voluntary contracts in Germany, and we have had a study published last week. We have something called Hausarztzentrierte Versorgung. It's a contract model where we have to engage in with general practitioners, and it should have elevated care. But what it did was it cost us 1 billion a year on top of care, and it produced zero measurable outcomes for the patients. So that's why you need the government. You have to enact. And I think you have to enact a mandatory reform. It must be outcome linked. It must be equity adjusted, or it will not work. And you have to start not a system as a whole, but you need to pick out a little space where you start. And I would suggest general practitioner and maybe medication management, because we know pretty well where medication management can fail, because more often than not it's binary choice. And in Germany, for example, we know that if we would leverage data at the interface between the general practitioner and the hospital better, we could prevent up to 65,000 deaths annually. And then you have to redesign that space end to end, and you have to put in the measurement, and you have to reward the practitioner for doing good work, for producing good outcomes. And then you have to adjust the measurement. If it fails, you have to put in, if everything is in place, mailer systems, because the system cannot absorb bad care if there is no aftercare or something like that. There must be a punishing mechanism. And then you have to look at it 2 to 3 years, and then you have to move to next. You can do readmission rates in hospitals, you can do surgical outcomes, you can do care transitions. And the great thing is all of those things are measured already. What is missing is the consequence. The consequence is outcome. So, like I said, you can be bold, you can do 4 at a time. but you have to be patient, you have to put in the work to get there at the end. That's the really hard part, because it transcends policy cycles, and you need consensus between the parties where you want to go. You don't have to change it up, and it's really, really hard. But in the end, it's a choice. And I, as a payer, I want to choose. I choose to pay for good outcomes. I don't want to pay for the system we have. So it might have been a very long answer.
No, but I think it's
I could have said just cautious yes.
No, but it sounds like it's really that an end-to-end transformation of the healthcare ecosystem is needed, right? With payers and lots
Yes.
of other stakeholders as well. Yeah, that would be good. So, going back to the consumer, and I'm kind of a consumer with my Apple Watch here as well. So, are we at risk of turning healthy people into permanently monitored patients? I sometimes feel monitored, like how many steps have I done, how well did I sleep, etc. So, yeah, what do you think?
I mean, it's a serious concern and something that we have to take seriously. We don't want to create stress for the individual, and we don't want to put strain on the healthcare system, right? At the same time, we have to be balanced, right? Because let's face it, it's very, very difficult to do preventative healthcare after people get sick, right? Very difficult. So we have to balance that somehow. And honestly, and you touched on this, and I really love that point. I'm more concerned of the fact that it brings inequality if this is not accessible to everyone. If it's just 1% that has these wearables, then that's not enough. And I really don't want to end up in a situation where, you know, it's only the Brian Johnsons of the world that have access to the whole team of doctors that can look at all signals and get these great health outcomes. I don't want that. I want to bring this to everyone in a way that, you know, that's accessible to everyone. I saw it was a great keynote yesterday. It was Skin Analytics, I think. I don't know if you saw it. So they have developed an app where you can scan your skin and you immediately get an answer if you have cancer or not. And I mean, that's a great way of relieving stress. All of a sudden you can check this very quickly. You don't have to go to the doctors. It's cheap, and it's a class 3 medical device. So you are not putting extra strain on the system because it's a validated device. And we want to go down a similar route with sleep apnea. So we're trying to develop, we're trying to get validated an app that from audio can do sleep apnea screening. So if you're worried, you can download it, sleep with it. In the morning, you know if you have a risk for sleep apnea. And it's validated, so we're not putting that stress on the system. So it is a valid concern, and we should take it seriously, but I don't think we should be too careful so we don't get the good outcomes.
It's the right balance in the end, right? I guess. So, Rob, one more question for you. As a kind of a longevity company, what responsibility do you have to really prove outcomes and not just only engagement in the sector?
Yeah, well, that picks up on your point, which is I think we've got a great responsibility to do that, but we have to be realistic. Creating a medical device takes 3 to 4 times longer than it does to simply provide something based on a wellness signal. And the reality is you're probably not doing much different in terms of interpretation of that signal. All you're doing is proving it clinically. Now that's really important, and it depends what you're saying. Are you saying that somebody has obstructive sleep apnea? That has to be a medical device in my view, right? Are you trying to measure the pulse oximetry using a ring? That has to be a medical device, and we have, you know, fairly firm guidelines set, particularly by the FDA now, on what a medical device is and how far you can go as a wellness device. So, you know, back to the women's health example of earlier, we had a vaginal sensor measuring temperature. Had to be a medical device because it's mucosal membrane contact. But the signals that we took from that, we're now able to prove equivalence with skin-borne temperature because we had that gold standard, because we published 13 clinical papers. So, absolutely, we absolutely have a responsibility to do these things properly. And frankly, devices are not going to be used by clinicians regularly unless you've proved clinical efficacy and you're not going to get reimbursement for them. So that connection is absolutely essential in my view.
Perfect.